First, let's talk about counseling about tinnitus. Very important. You cannot really manage a person who has tinnitus without really educating a person about what their tinnitus means and what kinds of things they can do to help learn to live with it. So for most clients, we need to discuss at a minimum the following topics. We need to talk about the incidence of tinnitus because patients and clients need to know how they might be affected and that they're not alone and that tinnitus really is a very common symptom. We need to talk about the auditory system and the possible causes of tinnitus. There are, as I will say, thousands of things that can cause tinnitus, and clients, patients need to understand that the tinnitus that they are experiencing is not being caused by something that's dangerous to them or that may have some terrible effects in their long-term future. We need to talk about why hearing loss can cause tinnitus. Very important because we're going to be talking to our clients about hearing aids, and so they need to understand how the hearing loss and the presence of tinnitus really tie together and why they're related to each other. We also need to talk about the fact that we understand the common difficulties that are created by tinnitus. When we are able to convey to our clients our understanding about what they're experiencing, it will build confidence in them that we can relate to the effects that they're having, which some of the people around them, their friends and relatives, may really not be able to relate to because they really don't have the understanding. We want to talk to our clients, very importantly, about the importance of getting a very thorough medical and physical evaluation, preferably by a specialist in ear, nose, and throat. And the reason for this is we need to make certain, first of all, that we're guarding ourselves and not providing treatment to somebody who should have been getting treatment from a physician. We don't want to be hiding or masking a serious medical problem. And we also want to be able to find out that there are no serious consequences of the tinnitus for the patient's own security. Patients need to be reassured that the fact that they're experiencing this annoying symptom does not mean that they have some horrible disease that's going to kill them or is going to make them deaf or similar situations. And then we want to make certain that our clients can understand that their brain is capable of suppressing this phantom perception and really can suppress many phantom perceptions such as amputated legs or phantom limb syndrome. Tinnitus is going to be a similar problem, and their brains do have the capacity to suppress these symptoms. So we're going to talk about things we could say to our clients in order for them to best understand it. So let's talk about some facts that we know about tinnitus. First of all, we know that tinnitus is very common. 15 to 20% of the general population have tinnitus, and interestingly, 70 to 85% of hearing impaired individuals experience tinnitus either on a constant or on an intermittent or sometimes on an occasional basis. The majority of people who have tinnitus fortunately report it as nothing more than a minor annoyance as opposed to a major problem. It's the individuals who report this as a major problem that we really have to focus our therapeutic intervention on. Providing information to your clients that have tinnitus is going to be something that's going to be highly gratified by the patient. The patients are going to be very happy that you have taken the time to explain what's going on in their head about their tinnitus because it's something that they may have had no knowledge about and may have not received any information about from other medical professionals. So I now want to bring up some of the facts also that we know about tinnitus. First of all, the most common difficulties that a person experiences when they have tinnitus typically relate to getting to sleep, and this is not something that we can minimize. This is a very important problem. When a client can't sleep well, they're going to have difficulty coping with this problem. We also know that it's the persistence of tinnitus And as I will say later, rather than the loudness that creates such a problem for patients. The fact that it's always there, the fact that it's unrelenting, they get no rest from it, is very annoying. For many people who have tinnitus, it's a matter of concentration. The presence of this background signal, no matter how loud or how soft, interferes with their concentration. And this becomes a major intrusiveness or annoying factor for many of our clients. What this does ultimately is it induces fear. When we as human beings don't know the cause of something and we don't know the consequence of something that may be dangerous, it's going to induce fear. And as I will point out to you, it's this fear that really creates the persistence of attention that's paid to the tinnitus. So one of our jobs as professionals is going to be help the patients get relief from the fear that goes along from noticing tinnitus. There's a number of things that can cause tinnitus, literally thousands of different factors that can cause tinnitus. Oftentimes we don't know what the cause is, but we do know that we could divide tinnitus up into two major categories: subjective and objective. Subjective tinnitus means that it's something that only the person experiencing it can hear. Objective tinnitus means that literally a person standing next to them or you as a professional holding a stethoscope to their ear can hear. Objective tinnitus is something that requires a physician's appraisal immediately. So if the person reports having a pulsating tinnitus or reports having a tinnitus that's clicking, for example, that's something you want to get the patient to the physician right away, because they are able to find out if it's something that's vascular or muscular related that might be able to be cured, or in an even more important scenario, that might be related to a medical disorder that needs to be identified and treated. So really, where is this perception coming from? Well, this is a slide that you don't have to know every single word on. It's a kind of a technical slide, but really what it points out are some of the major things that can cause tinnitus. So I'm just going to briefly take you through these 5 bullets. The first and most common cause of tinnitus is that it's related to a lack of stimulation from the peripheral system. So in other words, the cochlea is damaged, the inner ear is damaged, there's a hearing loss, perhaps in the high frequencies, perhaps in the low frequencies, but wherever it's coming from, the neurons in the brain that are associated with those nerves in the ear, those nerves in the brain are still functioning properly. It's the nerves in the ear that are not sending up the proper signal. And the brain always wants to receive a signal that it expects to receive. And the fact of the matter is that our brain is designed to always receive incoming sound. You know, we could close our eyes and cut out incoming visual stimulation, but we don't have earlids. We can't close our ears to shut out incoming auditory stimulation. So the brain always expects to receive auditory stimulation, and when it doesn't, it literally turns up its sensitivity. It turns up its internal gain to try to compensate for what it's not receiving from the ear. Another problem that we have is that when we have damage to our outer hair cells, when we have inner ear damage, in other words, it changes the inhibitory function that these outer hair cells provide. So it doesn't allow us to suppress certain outside stimuli, and we believe certain internal stimuli like tinnitus. There's also, as we'll get into in great detail in this next 45 minutes or so, we'll get into great detail about the fact that the limbic system, the emotional control center of the brain, is not processing properly when it focuses on the tinnitus. And we're going to talk about how we can help our clients learn how to control that problem. This problem is almost always related to fear or threat. If a patient or a client interprets the tinnitus perception as being something that is threatening to their well-being, it induces fear, that triggers the limbic system, and that is going to create a vicious cycle that we need to try to help our clients break. And then I just want to mention, although we're not going to dwell on it, the fact that Other things that are not even related to the ear can also cause tinnitus. People who grind their teeth at night, people who have neck problems. This can cause tinnitus because it can send a signal to the auditory cortex where sound is perceived. There's a number of things that can trigger tinnitus, and it helps the patient or the client when we talk to them about some of these potential triggers. Among the more common triggers are physical problems such as certain kinds of medication, a virus that they might have caught, some kind of an imbalance between the inner hair cells and the outer hair cells, or the excitatory or the inhibitory neurons, and as I mentioned, some other sensory influences like problems in the neck or in the jaw. There's also psychological triggers. A person who is worried about their spouse or their significant other having a medical problem or an illness, worrying about your job, worrying about money. These kinds of psychological triggers can really induce the perception of tinnitus. Retirement syndrome is something I refer to as individuals who have been very busy all their life, who have had their minds very much engaged, that now are finding that once they've retired, they have an awful lot of time on their hand, they have an awful lot of quiet environments, and that makes them think about their tinnitus more frequently. And as we'll talk about, one of the most common triggers for tinnitus is stress, and we'll get into this in great detail. So let's also mention some of the factors that can exacerbate or increase the tinnitus. They don't necessarily cause it, but they clearly can increase it. You can see on the screen caffeine, alcohol, smoking, which is not good for anybody, sodium, which is not good for people who have situations like Meniere's disease or something like that. Other medical disorders, high cholesterol, hyperlipidemia, thyroid issues, can be things that will increase a person's perception of their tinnitus. The two most common exacerbating factors, however, are going to be high noise exposure and stress. So what we're going to be talking about now as we get into the other steps are the basic assumptions that we can call upon to help our patient learn to cope with the tinnitus. The first assumption is that the brain is capable of sorting out meaningful stimuli from those that are not meaningful. The second is that attention is going to be directed towards features that are salient or attention-bearing, and if the person who has tinnitus perceives the tinnitus as meaning something important, usually something negative, then their attention is going to be drawn to it. So we're going to be talking to our patients about how the brain habituates or becomes accustomed to or acclimates to other stimuli. Very simple examples that you'll see in our counseling video refer to situations like having a ring on your finger, having clothing on. We don't sit and think about the clothing that are on us all the time. We don't feel our shirts or our pants or our socks. We don't feel our ring, but if I call your attention to it, then you do feel it. We don't typically respond to a refrigerator humming, and yet if it's novel, then you will draw your attention to it. So these are examples of stimuli that we experience much of the day that we can completely suppress without really thinking about it. So in summarizing this first step, the counseling area, which is such an important area, remember to counsel about the different things that you're seeing on the screen. Anatomy of the auditory system, the fact that tinnitus is likely a normal consequence of the hearing loss. By the way, it's surprising that people with hearing loss don't have tinnitus, but it's important for the person that you're seeing to understand that it is the hearing loss that is likely triggering the tinnitus, not the other way around. Our clients have to understand that tinnitus may be permanent. However, it doesn't mean that it's going to get worse. And in fact, for the vast majority of people, the presence of tinnitus tends to fade over time because their attention is not constantly drawn to it unless fear or threat is associated with it. It's the patient's or the client's reaction to the tinnitus that is the key issue that we have to help them deal with. And the purpose in our professional intervention with our clients is to help them to habituate to the tinnitus and not necessarily to eliminate it or cure it, as we would love to do, but we really don't have that capability at this point in time. The second step in managing our patients with tinnitus or our people with tinnitus is assessing the tinnitus and the effect that it may have on our client. We always begin with some form of a tinnitus questionnaire to get information about the otologic or ear or medical history of our client, about their audiologic, what's their hearing like, what's their understanding of speech like. We find out about other factors like their diet, their exercise regimen. Does exercise help them or hurt them? Their emotional pattern, how the tinnitus is affecting them. Their sleep pattern, we can't ignore that. If our clients are having difficulty sleeping because of their tinnitus, we have to help them, refer them to the right professional if necessary to get this kind of assistance. And we want to find out about previous treatments. You will be provided by Widex with a sample of a tinnitus questionnaire that you can hand out to your clients. There's certain essential tests that we have to do for our clients. One is we need to know what their hearing loss is like. If we're going to talk to them about hearing aids and the importance of sound stimulation, obviously we need to know about their hearing. So we have to measure an audiogram. We also need some baseline measure of the subjective reaction to tinnitus. So we have to assess how the client determines whether or not their tinnitus is a severe problem for them, a mild problem for them, no problem for them, or something that's completely changing their ability to enjoy life. There's a number of additional diagnostic procedures that some of you may engage in, and you could see some of these on the screen. I would caution you, if you are going to go into some of these more advanced audiologic testing, to be careful about assessing loudness discomfort levels and acoustic reflex decay, because it can, in fact, those loud levels potentially at least give the perception to the client that their tinnitus has gotten worse, and we don't want them to blame us as professionals for making things worse. Very important in this step is to help the client define the tinnitus problem for themselves. One of the most important things we can help our client with is helping them figure out realistically the time frame in which they're bothered by their tinnitus. Many of my patients will come in and I will ask them, tell me about the percentage of time that you're bothered by your tinnitus, and they'll say, I'm bothered by it 100% of the time. Well, we know realistically that they're not really thinking about their tinnitus 100% of the time. They're not thinking about their tinnitus when their mind is actively engaged in some very important matter, for example, or if they're engaged in some matter that they're getting great enjoyment out of, watching a football game, watching a TV show that they're laughing about, talking to their children. There are times when a person certainly is not aware of their tinnitus, and it helps if we can help our client understand the time frame in which this is a problem. For many, it's only a problem when they're in very quiet environments. For some, it's only a problem when they're going to sleep. So it helps to define this because our clients don't need to be thinking about this when it's not a problem for them. We also want to know what behaviors are affected. Is our client depressed? Are they anxious? If so, we may need to refer them to a professional who can help them with medication, for example. We need to know their attitudes and their thoughts, how they feel about the tinnitus. We need to know what affects the tinnitus. Certain foods, certain exercise, fatigue, things like that. And we want to know how our client's life what their life would be like if they didn't have tinnitus at all. This is something helpful to get them to realistically think about the impact of the tinnitus on their daily lives. We can use a number of subjective assessment inventories or severity scales that the patient or the client fills out, even in your lobby while they're waiting for you, to get a measure of how they interpret their tinnitus. You're seeing on the screen a number of very popular assessment inventories. One of them, for example, is the tinnitus handicap inventory. I'll just show you this one because it's one that is commonly used and is easy to score. And this is a simple 25-item survey that takes the client maybe 10 minutes to fill out, and they can do this, and then you can take. In addition to counseling, very frequently, in fact, in the majority of the cases, unless your counseling has given them enough reassurance that they feel this is no longer a problem, then sound therapy or sound enrichment or sound stimulation becomes very important. So when we talk about tinnitus rehabilitation or tinnitus management, as you can see from this slide, we're talking about a combination of sound therapy and counseling, and our objective is to produce or facilitate habituation, the natural ability of our brains to become accustomed to something so that we're taking a situation and instead of it being in the foreground of our consciousness, moving it into the background of our consciousness where a non-threatening or non-important stimuli belongs. So the role of sound therapy that we're going to talk about would be this. First of all, we want to provide some kind of sound to induce or to make the habituation to the tinnitus a little bit easier. I want to show you just a little graphic here that indicates why masking is really not the best way to go. If we look at this particular slide, we can look at this box in the corner here that shows a word, the word tinnitus. And let's think of this big green word as being the loudness of the original quality of the tinnitus signal. If we mask it and we put in a background noise that is loud enough that we actually change the quality of tinnitus, either by making it very soft because the outside noise is much louder, or by making the tinnitus not even audible, we've changed the quality of the signal in a manner that your brain can't habituate to something that it doesn't experience. So really the preferred way of going, that we now know after many, many years of research by a number of wonderful researchers, is that what we would like to do is change the background in the brain. Not the external background, but the background in the brain. And I've denoted this on this slide with a different color. We've made our brain green here. But you'll notice that you don't see the word tinnitus as readily as you did in the first picture, in the original picture, even though that word tinnitus is just as large and happens to be exactly the same color as it was in the original frame. We don't detect it now because we've changed our internal background. So that's what we're going to use our sound therapy for. So the terminology we'll just become acquainted with as we talk is masking, meaning covering up the tinnitus with a louder signal. Partial masking, meaning bringing down the loudness of the tinnitus because that external signal mingles with it or changes the quality of it. Mixing or mingling, which is probably going to be our ideal situation so that the brain is receiving both the perception of the tinnitus and the perception of this external stimulation. And then, of course, we're going to focus our attention on the use of music, whether it's unfiltered or filtered music, and specifically on the use of fractal tones or the Zen programs that are in the Widex hearing aids. So there's a number of current sound treatments, noise generators, maskers, music, hearing aids, which, as you could see on the screen, really just putting the hearing aids on is effective in over 60% of cases. There's also combination instruments, which in essence is where we could probably classify our Widex instruments using the Zen, because the combination instruments have both amplification and the presence of additional stimuli to mingle with the tinnitus. Of course, some of our clients are going to use home-based sounds, a fan, a sound generator that makes ocean waves or the sounds of the sea or something like that. And there are some commercially available compact discs that help a patient in terms of relaxation or in terms of partial masking or even mingling with their tinnitus. So, and one other point I should make here on these sounds. Many of the combination units that have been out there, even before Widex produced the Zen fractal tones, used a broadband noise generator because, number one, it's very easy to put into a hearing aid, and the fact is that broadband noise does, to some extent, reduce the contrast of the tinnitus to silence. And that's an important thing with any sound stimuli. If you're in a completely silent situation, the presence of your tinnitus is really going to stand out. It's kind of like walking into a room with a candle, and if that's the only light in the room, your eyes will go right to that candle. If, on the other hand, the lights in the room are bright, then your eyes will go wherever you decide they should go. So using a noise can reduce the contrast of tinnitus to silence, but the problem is that a noise may have a more short-term rather than a long-term effect, which is what we're trying to gain, and that noise may have more of a peripheral effect on the ears than it does on the brain, which is ultimately where we want to make this change. One of the other things about noise is that noise may require a longer period of time to help a person habituate because it's changing the quality of the original tinnitus. And once you remove the noise, the original tinnitus is still going to be there. So that may alter how habituation occurs in a natural manner. And the other aspect of noise that, in my opinion, and based on our research, we believe is an advantage for the fractal tones is that noise doesn't induce relaxation or reduce stress, and that's going to become very important for our patients. So we're going to use some kind of sound stimulation to interfere with the way the brain reacts to different activity. We're going to want to try to make the tinnitus more difficult for the brain to detect, and we're hoping that by putting external sound through a hearing aid into the brain, that it allows the brain to turn down its sensitivity to not try to overcompensate for the sounds that it's missing because of the peripheral hearing loss. Our goals in using sound really, you could look at it in a few ways. You could look at it from the perspective of active listening so that we try to distract a person from listening to their tinnitus, but that doesn't have a good long-term effect. You could use as a goal masking of the tinnitus so that the person doesn't hear the tinnitus, but that too doesn't have a long-term effect. What we want to achieve is habituation or desensitization to the tinnitus, and the best way to achieve that goal is through passive listening. The patient or our clients should not have to actively engage in listening to a stimulus in order to learn to habituate to their tinnitus, any more than you need to actively engage to not feel your ring on your finger or your wristwatch on your hand. You don't have to think about it to do it. In fact, if you do think about it, it sometimes will make it harder to ignore or to become accustomed to. So hearing aids can help our clients because they can, to some degree, mask the tinnitus, they reduce the contrast, they alter the production of the tinnitus peripherally by providing stimulation to the cochlea, but even more important, they alter the reaction in the brain by providing stimulation to those auditory nerves in our auditory cortex that are not receiving stimulation because of the hearing loss. We can create a structured pattern. We can reduce fatigue and stress when a person wears a hearing aid. And fatigue and stress, as we'll talk about next, can have a major impact on tinnitus. And we believe, and the research has shown, is that hearing aids can be useful in facilitating habituation. On the screen here, and I don't want to get into this to any great detail, but are some things you want to think about when fitting hearing aids. And we're going to talk about some of the selection of hearing aids later as one of our later steps. But there are a number of issues that you can talk with your Widex representatives to be thinking about in terms of certain aspects of your programming of the hearing aids when you're dealing with people who have tinnitus. The fourth step that we want to consider in managing our people with tinnitus is the connection between tinnitus and stress. We know that as I mentioned earlier, that when a person is fearful about their tinnitus, it triggers an emotional reaction. And there's a part of our brain that I'm going to show you in a moment that's called the limbic system, that is the region of our brain that is responsible for dealing with emotional situations. We have something called a sympathetic nervous system that, for example, tends to really alert or arouse people. And we have something called a parasympathetic nervous system that tends to relax or calm people. What our goal is to get these things in balance. When a person is fearful of their tinnitus, their sympathetic nervous system goes out of balance. It's more active than the parasympathetic nervous system, and we want to change that. We can all relate to some of these stress situations and what goes on in our body. An example that I use is if you're driving along the street and a policeman pulls up behind you, all of a sudden, you see those sirens, you hear the sirens, you see the lights flashing. Lots of changes take place in your body. Your heart starts to beat fast, your hands start to perspire, your mouth gets dry. And this is because your limbic system is creating a response, a defensive response, so that you could be ready to try to deal with this potential threat, so that you could think of a good excuse for why you were speeding or something like that. But this is called our fight or flight syndrome, where our brain tells our body to have more adrenaline going to our hands and our feet so that we could either fight the potential threat or we could flee from the potential threat. Stress occurs when this sympathetic nervous system becomes overactive. When it happens, there's a number of hormones released, which you could see on the screen. Chronic stress is not good for your body. Acute stress is good. Acute stress you need in order to take a test, in order to perform at a certain level. Having some degree of stress is important for us as human beings. But when it's when it's chronic stress, when it's there all the time, and if, for example, a person interprets tinnitus as being horribly dangerous to them, that's going to induce chronic stress. And chronic stress is going to have a significant effect on your physiology. The limbic system is a part of your brain that's located smack dab in the middle of it, and it consists of a number of structures, but the two most important structures are the amygdala and the hippocampus. The hippocampus being a part of the brain that stores and retrieves memories, and the amygdala being a part of the brain that interprets the threat and decides whether or not neurotransmitters such as adrenaline and cortisol and noradrenaline need to be released to deal with this threat. If we can accept the fact that stress induces physiologic changes and that tinnitus is impacted by stress, we could then start to think of ways to cut down the stress. And by the way, you will find that 99% of your clients that you ask, when you're nervous, when you're stressed, does your tinnitus increase? They will say, yes, it does. So it's a pretty safe avenue for you to go down in talking to your clients about the relationship between stress and tinnitus.